everyone, and welcome to the second webinar in our fiscal year 2019 webinar series titled Understanding and Documenting Opioid and Other Substance Use Disorders for SSI/SSDI Claims. My name is Pam Hine, Senior Project Associate with the SOAR TA Center, and I will be your moderator today. Before we begin, just a few housekeeping items to review. A disclaimer from SAMHSA. This training is sponsored by the Substance Abuse and Mental Health Services Administration and the U.S. Department of Health and Human Services. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Just a few webinar instructions. As a reminder, your lines will be muted throughout the entire webinar. This webinar is being recorded and will be available for download in about a week. You may download the presentation slides now and other materials by going to the top left of your screen and clicking on the file icon, Save Document, or visit the SOAR website at soarworks.prainc.com. Click Webinars on the left sidebar and choose today's topic. At the conclusion of the webinar, you'll immediately be redirected to a brief evaluation, which we kindly ask you to complete. And finally, we will save all questions and comments until the end of the presentations, at which time we will review instructions for posing questions to panelists via the Q&A function. Just go over some of the objectives. It is our intention that by the end of this webinar, you will have a better understanding of those key strategies for requesting and interpreting substance use-related medical records. Also, SOAR best practices for assisting SSI and SSDI applicants with opioid and other substance use disorders. And also how to effectively document opioid and other substance use disorders using the Medical Summary Report, the MSR. So to just review today's agenda, to help reach those objectives, we will begin this afternoon with presentations from Dr. Melissa Neal, who is a Senior Project Associate with the SAMHSA's GAIN Center at Policy Research Associates in Del Mar, New York. Then we'll have Amanda Starkey, who is a Project Associate and Subject Matter Expert on Substance Use Disorders here at the SOAR TA Center. And rounding things out with a local SOAR perspective is Rachel Phillips, who is a SOAR specialist with the PATH program in Troy, Michigan. And then we'll also end with plenty of time for question and answers, which are facilitated here at the TA Center. So providing today's welcome is Robert Grace, the SOAR Project Officer with the Homeless Programs Branch at SAMHSA. Bobby, would you like to do today's welcome?
Yes, thank you, Pam. I'd like to thank all of you for joining us today. On behalf of the Substance Abuse and Mental Health Services Administration, SAMHSA, and the Homeless Programs Branch of the Center for Mental Health Services, I would like to welcome you to this SSI/SSDI Outreach Access and Recovery SOAR webinar called Understanding and Documenting Opioid and Other Substance Use Disorders for SSI/SSDI Claims. SOAR helps states and communities increase access to Social Security disability benefits for eligible adults who are experiencing or at risk of homelessness and have a serious mental illness, medical impairment, and or co-occurring substance use disorder. Today's webinar will focus on the opioid crises in the United States in the context of people with disabilities who are experiencing or at risk of homelessness. We know that that opioid crisis has significantly impacted this vulnerable population. For SOAR providers, some questions remain. For example, if someone does have an opioid or other substance use disorder, what does it mean for their SOAR-assisted SSI/SSDI claim? Also, how do we effectively document substance use in the Medical Summary Report, the MSR. This webinar will help answer these questions and others which impact SOAR applicants. I would like to welcome and thank our presenters for your willingness to share your expertise with us. At this time, I'll turn it back over to Pam Hine, who will moderate today's webinar. Pam?
Thank you, Bobby, for providing today's welcome. We appreciate it. So now I'll turn the mic over to Dr. Neal, who will kick things off. Melissa, please begin your presentation.
All right. Good afternoon, everyone. Thank you so much to the SOAR TA Center for having me participate in today's webinar. I've been asked to provide a little bit of an overview of the opioid epidemic and some of the critical factors that are coming into play when thinking about people who are in recovery amidst the opioid epidemic. And first, I'm just going to cover some statistics around how this epidemic is impacting us. One way that we look at or quantify the epidemic is looking at drug overdose deaths. And the Centers for Disease Control and Prevention, we also call this the CDC, they have shown that since 2000, the rate of deaths from drug overdoses has increased 137%. And when we look specifically at opioids, we've seen a 200% increase in the rate of overdose deaths. And in 2016, which is the most recent data available, over 66% of drug overdose deaths involved some type of opioid. And so I'm going to go into some maps. You'll see on the right side of the screen a map, and these are produced by the CDC. You can go to their website and access this for yourself. If you download the webinar slides, you'll see this link, and that will take you right to these really helpful maps. And on the CDC website, you can go year by year and watch how just across the country there is a incremental spread of opioid overdose across the nation, so that in 1999 you see most of the country is blue, and in 2016 we see alarming areas of red, indicating high rates of overdose due to drug poisoning. Now, these maps do reflect overall overdose for all drugs, but again, a reminder, over 66% of drug overdose deaths in 2016 were due to opioids. And so just a few more statistics around this epidemic. In 2016, the number of overdose deaths involving opioids was 5 times higher than that in 1999. So when you think about that blue map and compare it to the colorful map, the overdose deaths was about 5 times higher. On average, about 115 Americans pass away every day due to an opioid overdose. And some of the contributors to this are in this graphic, also produced by the CDC. And one thing I do like to point out to social service providers is that we often hear a narrative in terms of who is bringing drugs into our communities and how people are accessing drugs. But it's important to consider that the first wave of opioid overdose deaths came from misuse of prescription drugs. And so the reality is that many people's substance use disorders started in physicians' offices. And that's really important for providers to think about when they're trying to understand their client's history. The other thing this graph begs us to ask is, what war on drugs? And so since the early 70s, we've had some really aggressive political campaigns talking about being tough on crime and having a war on drugs. And that has resulted in a disproportionate number of people of color incarcerated in state prisons and jails and federal prisons. And when we look at the data, many of them are incarcerated due to convictions related to drug charges. And so when we think about that and then we look at this data, we have to recognize that despite the war on drugs and many people being incarcerated, we still are wrestling with the reality that overdose deaths have not gone down, and the rate of substance use disorders has not gone down. And so this is an important consideration to think about as you work with people of different races and ethnic backgrounds. That's an important piece of history to think about. Trauma is another aspect that we need to think about when considering recovery amidst the opioid epidemic. And trauma is highly prevalent. Nearly 90% of U.S. adults have experienced a traumatic event based on DSM-5 criteria. Many adults have experienced multiple traumatic event types. And just one way that trauma can impact us is through the development of PTSD. And so we see among U.S. adults, about 8.3% will experience the symptoms of PTSD in their lifetime. And it'll be no surprise that trauma is very prevalent among our veterans who have served in the military, and going above and beyond thinking about those who have served in Iraq and in Afghanistan. Also, people who served in the Vietnam War may still be dealing with the aftermath of traumatic events that occurred to them, and those things could still be affecting their lives today. Another way that people experience trauma through their service in the military has been the experience of sexual assault or sexual harassment. And so statistics show about 23% of women report sexual assault while in the military, 55% of women and 38% of men report sexual harassment during their time in the military. And those are experiences that can result in trauma and the effects. So trauma affects us each very individually. A lot of how we respond to trauma is based on physiological makeups. And so brain development, stress response mechanisms, immune system responses all come together to shape how we each respond to trauma. So as you work with clients, you're going to see that one person may react to the exact same traumatic event in a very different way than another client. The mental and emotional effects of trauma also vary widely. And so one person may resort to more of a state of powerlessness. Another person may show high levels of fear and constant state of alertness. So also that's something to keep in mind as you're interacting with clients. Just the way that trauma affects them is going to show differently. And as I mentioned before, unresolved trauma can result in mental and substance use disorders. And so that's why trauma really is an important thing to understand as you are trying to explore your client's history and better understand what substance use disorders are there and why. However, unresolved trauma also can result in suicide, chronic disease, and premature death. And it's important, I think, for people to recognize the link between trauma and chronic disease, as most people don't think that those things go together. Some current trends in addressing some of these issues that I've just covered. Right now, we do see a little bit more of a public health approach versus a criminal justice approach to addressing the substance use issues and the opioid epidemic as overall. And much of this, we hope, is because there's increasing evidence that documents that substance use disorders are a disease or a medical condition. And so society is, and many of our stakeholders are increasingly recognizing that. And as a result, we are seeing more diversion from the criminal justice system into treatment. For example, there are even now police departments that have programs where people with substance use disorders can go to the police department and be transported somewhere where they can receive treatment without facing the threat of a criminal charge. So that is a very promising trend. We're also seeing that victims and their families are more humanized, and when we contrast this to the crack cocaine epidemic a couple of decades ago, We see that the people who have substance use disorders and their families now, are humanized more, and their stories are shared more broadly. And media has had a lot to do with that. Increasingly, media is elevating stories to really share the voices of people who have been impacted by the opioid epidemic, as well as help disseminate some of the solutions that communities have been testing out and have found effective in addressing opioid use in their communities. So another aspect to think about when we are considering recovery in the midst of the opioid epidemic is that there are unique risk factors for service members, families, and their veterans. And the military culture is, very effective, very necessary for the safety and the organization of people during their time in the military. However, those people can also face challenges when they are transitioning back into their homes and their communities where the culture looks very different. And so we see veterans have challenges in making those transitions. We see high rates of co-occurring disorders. Many veterans report chronic pain, and we see an elevated risk of suicide among service members, veterans, and their families. And so, as I mentioned in the previous slide, the military culture sometimes has this unintended result of decreased help seeking. And service members and veterans have said that by seeking treatment, they fear being seen as weak, they fear that leadership might treat them differently, or fear that others might have less confidence in their abilities. And so as a result, we do see high rates of co-occurring disorders among veterans. Among people who have not served in the military, co-occurring disorders are high. About 83% of adults with substance use disorders have one or more co-occurring mental health disorders. And so we anticipate that's going to be the same or even higher among veterans due to their invisible wounds of war. However, it's harder to get the numbers around that. Right now, what we know is 25 to 33% of veterans with a substance use disorder also meet the criteria for mental health disorders, but that's just among those veterans who seek treatment. And the research shows that veterans are typically just inclined to seek treatment when they are considering or they know they're going to be redeployed. And so what we know is there's a large group of veterans out there who are not seeking treatment, and so we don't have a good measure of how many of them have a co-occurring substance use and mental health disorder. However, veterans are more likely to report the experience of pain, and we do see that 45% of service members and 50% of veterans report experiencing pain on a regular basis. And this is about double the number of people in the general public that report pain on a regular basis. And among service members, we see about 11% report misusing prescriptions, with opioid pain medication being the most frequently misused. And so this, again, is just current service members. So thinking about veterans and the fact that they report experiencing pain on a regular basis, we know that veterans are prescribed opioids for years. We also then can take the next step and reasonably assume that veterans may also be misusing opioid pain medications. And so some of this is driven by access to care issues. Not all veterans are eligible to receive VA care. Not all veterans want to receive VA care. And the VA centers in different areas have varying capacity to provide services. So some VA centers are able to provide or cover chiropractic care as an alternative to opioid pain medication. Other VA centers aren't able to provide those kinds of services. So, we see a lot of different access issues depending on where the person is located. Some successful approaches to reducing opioid use disorders among veterans include the drug monitoring programs, increased access to medication-assisted treatment, peer supports, including veteran mentors, veterans treatment courts, and so forth. And finally, we're going to look at just briefly at homelessness as an aspect of thinking about recovery amidst the opioid epidemic. And housing is a critical social determinant of health. A person's ability to be housed is directly linked to recovery and wellness outcomes. What we see nationally is that about one-third of people experiencing homelessness also report having an alcohol or drug problem. 2/3 of people experiencing homelessness have had more of an official substance use disorder during their lifetime. 75% of people experiencing homelessness have also had a co-occurring substance use and mental health disorder. And the most disturbing statistic here is that 81% of overdose deaths among people experiencing homelessness are related to the use of opioids. And some of the promising practices for working with people experiencing homelessness have been incorporating a housing-first approach. So having those programs where someone is just placed in housing without requiring them to be sober first or to go to treatment first or to complete any other requirement first. They're just placed in housing and then supported to consider or to enter treatment later. And most of these programs are supportive housing with case management or other wraparound services. Many of the most promising Housing First programs provide permanent supportive housing versus transitional, and that's because this group that is experiencing homelessness and substance use disorders typically have been dealing with this chronically and need a lot of time and a lot of support to really stabilize and to make progress on their path to recovery. Other effective Housing First approaches incorporate peer support. So having those people with lived experience, providing some of those case management services, and really helping people along their way on a day-to-day basis has been effective. Many of our housing programs also are using more informed program requirements. So their structures and the way that the program is run supports stability, knowing that if that person can stay stable, they're more likely to recover and they're more likely to see improved outcomes in terms of their substance use and mental illness. Another focus is that more of these program requirements have a recovery focus. And so when someone is not complying with rules or expectations of the program, there's more of a recovery focus rather than a punitive approach when trying to address the person's behaviors. So this is the end of my presentation where we have just touched on trauma, risks to service members and veterans, and homelessness as 3 things to think about when considering recovery amidst the opioid epidemic. And now I'm going to transition things over to Amanda Starkey with the SOAR TA Center.
Thank you, Melissa. Hi, everyone. Thank you again for joining us on this important presentation. My name is Amanda Starkey, and I'm a project associate at the SAMHSA SOAR TA Center. Before joining the TA Center in 2017, I worked as a SOAR case manager in a few different organizations throughout Michigan and Colorado, and I've helped represent about 200 or so applications using the SOAR process. So throughout all of those applications that I helped represent, I saw a common challenge when it came to co-occurring disorders. In my portion of the presentation, I'd like to provide more insight into SSA and DDS's decision-making process and key strategies for addressing co-occurring disorders in medical summary reports. So first, let's talk about DA&A. So the Social Security Administration uses the term DA&A to describe drug addiction or alcoholism. The Social Security Administration uses the term not otherwise prescribed, and that means that the side effects from prescribed opioids can be considered an accessory to a disabling condition. So they're only looking at drug addiction and alcoholism and the effects of it when they are non-prescribed substances. So under SSA's rules, DA&A is not considered to be a disabling condition. So drug addiction and alcoholism beyond what is prescribed by a treatment provider is not considered a disabling condition. However, SSA and DDS are not blind to the reality that in a lot of cases, a legitimate mental disorder accompanies a drug or alcohol addiction. So SSA is aware that co-occurring disorders exist, and they do recognize this. So our job as SOAR case managers is to present evidence that will, as clearly as possible, distinguish the effects of mental illness from the effects of drug or alcohol abuse. So what does SSA mean by materiality? Current SSA law states that if substance use is found material to a person's disability, SSA benefits will be denied. Materiality refers to the extent of which substance abuse contributes to the applicant's impairments. So if the applicant still experiences severe impairments that result in significant functional deficits and an inability to earn and maintain substantial gainful activity level work during periods of sobriety, then their substance abuse will not be considered material to their disability. SSA law also states that the applicant has the burden of proving disability throughout the unique sequential evaluation process used for DA&A cases. So beyond the sequential evaluation that we learn about in our SOAR fundamentals trainings, SSA uses another sequential evaluation to determine the materiality and the eligibility for benefits when conditions are accompanied by drug abuse or alcoholism. So this means that enough evidence needs to be provided in the records and other submitted materials to clearly illustrate that the applicant meets or exceeds the requirements to move on to the next step or be approved at step 5 or 6 of this new sequential evaluation, which we're going to talk about on the next slide. As SOAR providers, it's our job to clearly present the information that supports disability. So I took a picture of the actual sequential evaluation that SSA uses to analyze drug or alcohol use with disability, and I'm just going to walk us through the steps. So in step 1, SSA asks the question, does the claimant have DA&A? If the answer is no, the evaluation is not necessary because they don't need to make a determination on if the drug or alcohol use is material if it does not exist. If the answer is yes, the claim will move on to step 2. Step 2 asks, is the claimant disabled? So if the answer is yes, that they're disabled, the application will go on to the next step. Even without the substance use, or with the substance use, the applicant still is able to earn substantial gainful activity, they wouldn't be considered disabled and they wouldn't need to be evaluated under this sequential evaluation. Their case would just be denied. Step 3 asks, is DA&A the only impairment? So this question is pretty straightforward. If DA&A is the only thing that's preventing this person from being able to work, then their case will be denied because Social Security does not consider DA&A as a disabling condition. If the answer is no, they have other impairments that go along with the DA&A, it'll move on to step 4. So step 4 asks the question, if the condition alone disables the claimant while actively using. So for example, if someone meets the listing criteria of a physical impairment, but they continue to use non-prescribed opioids to treat the pain from that impairment, they could still be considered disabled and they could be allowed on the case, because whether they use opioids or not, they still have this physical disability that meets the listing criteria. If the answer is no, they could be denied. Step 5 asks, does the DA&A cause or affect the claimant's medically determinable impairments? If the answer is no, then the case will be allowed. So they have the medically determinable impairments, and DA&A is not the cause of this, so their case can be allowed. If the answer is yes, the DA&A does cause their impairments, but the impairments are irreversible or could not improve to the point of non-disability, even if they stopped using the drugs or alcohol, the case can still be allowed. The only time that the case would move on to the next step is if the drug abuse or alcoholism is clearly affecting the claimant's medically determinable impairments, and it's not clear whether those impairments would be irreversible or if they would not improve. So then it moves on to the 6th step in the sequential evaluation for materiality. And that asks the question, would the impairment improve to the point of non-disability in the absence of DA&A? If the answer is yes, it will be determined that the DA&A is material to the person's disability and the application will be denied. If the answer is no, that even with the lack of drug addiction or alcoholism, the impairment will not improve enough to be considered non-disability, the case will be allowed. So I think this is a new perspective for SOAR providers who haven't seen this before. It gives us a better understanding of exactly what SSA and DDS need to understand when they're presented with a case with a co-occurring disorder. Which leads us to this slide. So it's really important to understand what you need to know. So we need to show that the person meets the threshold of their drug addiction or alcoholism not being material to their disability based on those sequential evaluation steps. So it's good to have a strong understanding of this before we move forward in working with our claimant. Ways you can do this is to ask the right questions, collect information from a variety of sources. A robust compilation of evidence from both medical and non-medical sources will help to clearly illustrate the applicant's substance use and the extent to which that substance use impacts his or her life. You can use the medical summary report interview guide to do this. I've included a picture of the section on substance use from the MSR interview guide on the right side of this slide. And you can use this to help guide your questioning and find some more information on the person's use history. And most importantly, just allow the applicant to tell his or her story. A medical summary report is a really unique opportunity for the applicant to tell his or her authentic story. A lot of times we get the most valuable details when the applicant is offered the opportunity to speak openly without judgment. And it's our goal as SOAR providers to understand and clearly depict the applicant's story. This is their only chance a lot of times to tell the disability examiner what's really going on in their life and the impact mental illness and substance use has had. So things that are important to know before we get started with writing the MSR when it comes to the substance use section. So what does the person use? It's really good to get that out in the open to know what you're working with. What drugs or alcohol does the person prefer, and what have they used in the past? What purpose does this serve? If a person is feeling depressed and they're using a stimulant, how does he or she respond? What about someone who abuses opioids to help them become numb to PTSD symptoms? So these are really good details to understand, and a lot of times this isn't provided in the clinical records. It takes us having a good open-ended conversation with our clients to truly understand what purpose the drug use or alcohol use has in their life. How does it interact with symptoms? So if he or she is using to self-medicate, what triggers the need to use? I worked with a client who had intermittent explosive disorder a few years ago, and he used heroin to help suppress his rage. And that was a really important part of the story for us to tell, and it wasn't in his clinical record. How does it impact their physical and mental impairments? Does the drug addiction or alcoholism exacerbate the symptoms of their physical or mental impairments, or does it help lessen their symptoms? And how is it relevant to their disability? So a lot of times the opioid use is a response to an injury, chronic pain, or mental anguish that the applicant's experiencing. It's important to understand its relevance in relation to the applicant's disabling condition and to clearly depict this in your medical summary report. So I've come across a common theme from what I've been saying about the applicant's substance use and mental health history. So Department of Corrections records, they have great examples of functioning during periods of sobriety. So were behavioral services needed during incarceration episodes? Anything you can garner from jail or corrections records is helpful here to talk about what's going on with the person's functioning when they're sober. In neuropsych evaluations, we're going to talk more about this in a few slides, but I wanted to mention it here also because they can help distinguish underlying issues that might be related to brain functioning that otherwise wouldn't be noted in their clinical records or could be chalked up to side effects of the drugs or alcohol that the applicant is using. So those are some medical sources of information. Collateral sources, you can talk, of course, to the applicant or their case manager. Shelters are a really good source of collateral information. In my experience working as a SOAR case manager, shelter managers provided really great collateral details about the applicant's functioning and their substance use patterns, and how they're functioning after an all-night stay in the shelter when maybe they've come down from the drugs or alcohol. What are they like in the morning? The shelter managers can provide a really nice depiction of their behavior and functioning. So family and close friends are also good sources of information about the role substance use plays in the applicant's life. Of course, you need to get a signed release and permission from the applicant to talk to support people, but they can provide some behind-the-scenes details about the person's history and their current use patterns. So the Medical Summary Report Interview Guide is a really important tool we can use as SOAR providers to garner the right information from our applicants for writing a very effective substance use history section in the medical summary report. There's sample questions provided for you. Just remember to keep your questions open-ended, like tell me more about or how do you feel when. We want to create a safe environment where the applicant feels able to truly open up to us as their SOAR providers and advocates. And follow up to get a clear picture. So sometimes this involves revisiting conversations at a later date. If something's too much, or if you don't think you're getting the true picture of what's really going on, maybe bring it up in the next interview. Hey, I remember you said this last week. Let's talk more about that now. Maybe you can get some more details that the applicant wasn't willing to share previously. And using the clinical records to help ask questions. So sometimes applicants can't remember timeframes. And the good thing about clinical records is they're always dated, so you know what period of their life the substance use is happening in. Another good use of clinical records is to look for toxicology reports. So if you see a toxicology report in ER records that show substance use not initially discussed, so for example, someone tested positive for methamphetamines in their ER toxicology reports, you can say, hey, I saw your ER reports from 2014. They're showing you tested positive for methamphetamines. Can you tell me about what was going on then? It might trigger some memories and encourage the applicant to be open with you. So I just wanted to give a short story about that. I was working with a client last year, and she told me that she was sober for several years in the mid-2000s. She'd been previously addicted to crack cocaine, but she said she got sober in the 2000s when she was raising her sons. So I looked over her clinical records, and I kept seeing positive toxicology screens for cocaine. So I brought this up to her, like, you know, I know we talked about it, and you said you were sober between 2008 and 2012, but your records are showing positive tox screens. And her response was, oh, yeah, I was sober. I just partied on the weekends at that time. So that was her story to tell. And it also gave me some insight into her understanding of sobriety and her mental state at the time of our interviews. So you collected all the evidence, you have the clinical records, you had an interview with the applicant and asked them about what their substance use history was like, and now it's time to present the information in chronological order in the medical summary report. So it's important to start with initial use and work forward. So asking questions or describing what was going on when the applicant first started using. Was there any type of family trauma, abuse, or neglect happening that led the applicant to use hard drugs or alcohol for the first time? And then you want to go on to discuss how the relationship with drugs or alcohol has progressed over time. So what happened since that initial use? Does the person use chronically or on a binge basis? Did they go through periods of sobriety and relapse? And what happened to trigger those relapses? These are all really important details that we can include in our substance use history section of our medical summary report. And you want to use the clinical records to find more clues. Like I said, ER notes, case management notes, group therapy notes are really good pieces of information to look for clues about this. In group therapy, you can see how the person responds in a group setting during periods of sobriety. Are they outgoing, or do they keep to themselves and have trouble opening up in a group setting? So throughout your substance use history section, you want to continue to make the links between symptoms and sobriety. It's important to clearly describe what symptoms of mental illness are present during periods of sobriety. The clinical and criminal justice records are great resources for this information. So if someone had an extended stay at a psychiatric hospital for a week or so, case notes and nursing notes about their behavior on the floor during that time can be really valuable details to include in your report because they were sober during the time that they were hospitalized. Likewise for periods of incarceration. If they had to seek treatment for behavioral health in jail, it's important to note that in your report because these are most likely periods of sobriety where the applicant still needed psychiatric treatment. And it's our job to advocate for our consumers. It's our unique and very special responsibility to help them tell their story. Our medical summary reports may be the only piece of evidence available that explores the complexities of their co-occurring disorders beyond just short clinical notes from treatment providers. And you need to use your knowledge of materiality to frame your writing. So think about how SSA evaluates materiality in their sequential evaluation and apply that to the section on substance use in your medical summary report. And constantly ask yourself if your report is answering the question of, does the applicant still experience symptoms during periods of sobriety? These are all great, they're great great strategies I've used over the years as a SOAR practitioner to help support my cases. And I just wanted to end my portion of this presentation with a brief example of someone I worked with in about 2012. So this man was named Chris. He was a middle-aged man who was referred by his case manager at the local community mental health center where I worked as the SOAR specialist. He was staying in a shelter, and he spent most of his time at the day center. So this guy came in his referral, and he had a really long history of mental illness. He had physical impairments. He walked with a limp and used a cane. He had an intellectual impairment that was supported by special education records going back to the 1970s. And he was recently sober about 9 months after 20 plus years of alcohol and drug dependence, mostly with crack and cocaine addiction and alcohol. And his main diagnosis was bipolar disorder. So before I met with him, he was denied 5 times prior to engaging in the SOAR program. So I was a young SOAR practitioner and super optimistic, and I knew I was going to help this guy. So we got to work. Right off the bat, my direct observations, it was really obvious he had some odd behaviors and slight problems with his balance and speech. He would slur some words. Even with the use of a cane, he had some balance issues. I tried my best to do some compassionate interviewing and providing a safe environment during our chats. And eventually I asked if he'd be willing to participate in a neuropsychological evaluation to explore some of the symptoms I noticed. He agreed. He was a little hesitant, but he agreed. And I worked with his case manager to help get the evaluation scheduled through the community mental health center. So after his neuropsych eval, I received the report back, and the results were pretty fascinating. So on one of the tests, he was asked to copy a simple picture of some shapes, and he actually drew a mirror image of the shapes, and the report confirmed that this was indicative of a neurocognitive disorder. Back then, it was called an organic brain disorder in the report. So the neuropsychologist wrote in the report that due to his past alcohol abuse, his brain chemistry was irreversibly changed. So that goes back to that sequential evaluation where even though he stopped drinking for 9 months, he has irreversible damage from his substance use that will not improve over time. So I obviously included this new record and the information from it into his medical summary report, and his case was approved in 70 days. He received $12,000 in retroactive benefits, and he had a $1,340 ongoing monthly SSDI benefit after that. This gave him validation. He felt crazy all of these years applying for benefits and getting denied when he knew something was wrong. This validated that he really did have a diagnosis that was worthy of a disability decision, and he was more committed to treatment. He got housing, and he continued his recovery with case management. And another bonus of this situation is that his therapy teams gained insights into his conditions based on the findings for the neuropsych evaluation. So it was just all around a really positive outcome to a man who spent years in a really stressful situation. So this concludes my portion of the presentation, and I'm going to turn things over to Rachel Phillips, who's a SOAR case manager at Community Housing Network in Troy, Michigan.
Thanks, Amanda, and thanks again to the SOAR TA Center for having me here for this webinar today. Today I am going to go over some strategies and tips that I've used to help complete some successful SOAR claims for clients who have co-occurring disorders. I'm going to start by providing some information and statistics about the area that I work in here in Troy, which is a suburb of Detroit, Michigan. And these statistics are from 2016 and 2017. You can see them here on the screen, but I want to really highlight the fact that there's been a 61% increase in opioid-related deaths and 5,720 individuals who are currently, or I'm sorry, not currently, but in 2017 receiving outpatient treatment for opiate abuse. And as we know, Dr. Neal kind of covered this earlier in the presentation, this really disproportionately affects those who are experiencing homelessness, and that is a major part of working as a SOAR practitioner, is helping those folks. Here at Community Housing Network, I work on the PATH team, and for those who are not familiar with PATH, we provide outreach and SOAR assistance to people who are experiencing homelessness or at risk of homelessness. We focus on the most vulnerable, chronically homeless, or who have a high vulnerability index. We meet with folks where they're at, so that could be outside at a park, a parking lot, under a viaduct. It's really everywhere and anywhere, and that's how I receive my referrals for SOAR. As a SOAR specialist here, I review our referrals, I screen for further eligibility, and then I implement the SOAR critical components of collecting the medical evidence and doing the SOAR guided interviews, connecting people to other resources and services, and if needed, we refer for appeal and legal aid. Okay, so some of the most successful strategies that I've used to help our clients who have co-occurring disorders throughout the SOAR process are isolating periods of sobriety in the medical documentation. And Amanda kind of touched on this throughout her presentation, but this is super important when you're reviewing medical records to really go through and look at those inpatient treatment dates and identify the marked symptoms that are occurring throughout those dates. So using the Blue Book analysis that's offered through the SOAR TA website, they provide that. And kind of going through and seeing what symptoms need to be marked in order to help this client get an approval from the determination examiner. So identifying those inpatient treatments and marking those symptoms while they're there. Also looking for tests like the urinalysis, toxicology reports, and any of the blood tests or metabolic panel exams. Can really help to identify dates and specific time periods where that individual was not using but still experiencing their symptoms of mental illness. And also, looking for the mental status exams are huge because those will have those marked symptoms on there. The interview process is another place where I really try to pull out some of the things that wouldn't necessarily be noted in someone's case notes from their medical treatment provider. So it's a little bit of relationship building and engaging in meaningful conversations regarding that individual substance use, asking when the substance use began, what triggers the use, and what symptoms they're experiencing throughout those periods of sobriety can be really huge. And Amanda said this in her presentation as well, is getting their story is really important. I even sometimes create a timeline based on their self-reports so that when I am reviewing their medical documentation, I have that information to kind of cross-check and be like, okay, well, I know that this person said that this was going on in their life at that time and they weren't using. So I'm going to really try and dig through those records and see what I can find as medical evidence to support that. And I keep that timeline with me in their file so that at any time I can go back in and kind of add to it if they remember certain information, or mark when they get new records in and cross-check it against that information. Utilizing the medical summary report, again, is your best friend. Linking their trauma to their substance use or other diagnoses is really huge. It's been mentioned a lot throughout this webinar, but SOAR really provides that opportunity for us to tell their story and for the examiner to get to know the person behind the stack of papers that are coming to them for this determination. The self-reports are super helpful within the medical summary report. And when the medical documentation is lacking or not thorough and they don't have a very strong treatment history, utilizing community partners for collateral information and collateral letters has been a huge help for me as a SOAR practitioner as well. There have been many times that we've contacted local shelters, parole officers, case managers, or people who are involved at like faith-based organizations to provide information for that person of what they are like when they're not using, or if they do use and they're not using when they wake up in the morning, then what's their attitude, what's their mood like then, how are they interacting with folks? And this has been a huge help for individuals where the medical documentation may not be as strong. So I have two case studies today that I want to talk about, and both of these individuals had co-occurring disorders. The first one, a 35-year-old female PATH program participant, Jane. Jane was diagnosed with borderline personality disorder, major depressive disorder, generalized anxiety disorder, and had a substance use disorder as well. She was utilizing methadone treatment at the time of her referral, and she was also referred actually by her methadone treatment coordinator for SOAR. Throughout the SOAR process, Jane was able to provide really thorough information regarding her use and past trauma and what triggered the use, which really helped in developing her application and her medical summary report. And ultimately, Jane was approved by explaining these experiences within the medical summary report and isolating those periods of sobriety within her medical records. We were able to meet the listing criteria, and Jane's SSI application was approved. And that was a pretty quick turnaround on that one, I believe. I don't have the exact day, but I remember that was a pretty quick one. Oops, I went ahead a little far. My second case study here is for John Doe. John was a 31-year-old male PATH program participant. John had intermittent explosive disorder, major depressive disorder, generalized anxiety disorder, and a potential traumatic brain injury. So he had a substantial history of substance use and even reported some current use as a means of coping with his symptoms. This particular case required a really extensive review of the medical records in order to, again, isolate those symptoms during periods of sobriety, particularly during periods of inpatient hospitalization and rehabilitation, which he had several of. And throughout the interview process, John was able to share that he would be triggered to use after experiencing some of the symptoms of his mental health diagnoses, and often use those substances as a way of coping with his illnesses, injuries, and conditions. So by including all this information in his medical summary report and highlighting those periods of sobriety within his medical documentation, John's application was also approved for SSI. So these are just a few ways that as a SOAR practitioner, you can work with your clients who have co-occurring disorders and really draw out the necessary things that you would need to help get them approved. And that wraps up my portion for the day. Thanks again.
Thank you so much, everyone, Dr. Neal, Amanda, and Rachel, for your really informative presentations. We have a bunch of questions come in already, but if you'd like to ask your question, just please type it into the Q&A box on the right-hand side of your screen. That's how we'll be taking questions. If we don't get to an answer, we'll be sure to distribute these to the panelists for a response after the webinar, just in case we don't get to everything. We did get some really great questions, and again, some came in before the presenters were finished, so I hope that maybe these were answered already. So I'm going to go ahead and pose this question, and I think Amanda, then maybe Rachel, will comment on it. So do you have any tips for this when using a function report? And I'm thinking that your presentation really discussed the value of the substance use history section of the MSR. Could you comment on that if folks are also submitting a function report and making sure that an MSR is included with that? Can you talk about that a little bit?
Sure. This is Amanda. That's a good question. So the function report does not address substance use history, so this would be a good opportunity to make use of the remark section, and you can discuss their functional impairments during specifically periods of sobriety. And I think that's the best way to incorporate this into a function report. If there are questions that ask about their day-to-day functioning and they seem to be worse during periods of sobriety, you can make sure to carry that over into the remark section as well and say, when the person is sober, they have trouble getting out of bed because they're so depressed. Sometimes they binge on cocaine just to get through the day, to get things done, something like that. So I would suggest really utilizing that remark section in the function report. Rachel, do you have anything to add?
No, I think you about covered it on that one.
Great, thanks. I think that's a great tip, to use the remark section to add information about periods of sobriety when symptoms are present. That's really great. So if you're submitting function reports along with an MSR, highlight this information in remarks, because we know that the DDS adjudicators will read that. Great. Here's another question. And Amanda, you might want to start taking this, and Rachel jump in, because Amanda, your case study did address this to some extent, but this has to do with if someone has liver disease due to alcoholism, which is, again, another irreversible condition that's not going to get better. So if someone has a liver disease due to alcoholism and the liver disease will not improve, will they be denied?
So that goes back to the sequential evaluation of materiality. So again, their liver disease is not expected to improve even with the absence of substance use. So they will not be denied for record, or denied for benefits based on their substance use because of that. If they meet all other requirements for disability, the substance use won't play a role in the determination because they are going to have this chronic condition either way. It's not going away if they stop using alcohol.
Right. That's a good response. Again, I think that's a big misconception, too. If the condition was maybe caused by alcohol or other drugs, that they would be denied. But, like other conditions, it would be looked at separately and, to see if the person maybe met the listing for liver disease. How bad is it? How severe is it? So that's really great to get out there. Because you might see that, you might see hepatitis C that was caused by drug use. You may see some other conditions as well. So Social Security will evaluate that by looking under the appropriate listing of impairment for that. Thanks for that. So I think this was Amanda who was successful in getting the neuropsych eval. What advice would you give to SOAR case managers who would like to get neuropsych evaluations but have but the applicant has no insurance for that. Do you want to talk about your particular case or any strategies for maybe getting funding for a neuropsych, if you think that could really be helpful for their treatment and their disability case?
Yeah,
Sure.
so I think neuropsych evals in general are really, really valuable pieces of evidence, but I also understand that they are expensive and nearly impossible to come across if you don't have insurance. In the case study I was referring to, Michigan had a specific program for people experiencing homelessness that offered health insurance, so he did have insurance that covered it. When I worked in Denver, there wasn't a program like that, and we teamed up with the local university, University of Colorado, and their psychology department performed the neuropsych evals on a very reasonable sliding fee scale based on income. We also set grant money aside under our admin costs to pay for neuropsych evals for our nonprofit organization if we deemed them to be necessary for the case.
Great. Those are good tips and places to go to help fund some of these more expensive evaluations and even testing. Here's a good one that I think Rachel and Amanda, you've both seen for many of your SOAR applicants. Are there strategies to counter frequent emergency room reports of intoxication? It seems like these reports are ERs used to seeing him there for alcohol and not noting other symptoms. So when you get emergency room records and you're just seeing the person treated for maybe alcoholism or, maybe an overdose or something else, how do you discuss those in your MSR? How do you talk to the applicant about these, especially if it says here if the report says that the client is quote unquote normal or no other symptoms are discussed other than maybe just for intoxication?
I can go ahead and try and answer that. This happens a lot with a lot of the folks that I work with, and what I really try and do is when I read all of those emergency reports and see that maybe, this is all happening within a 2-month range, and then it kind of calms down for a little bit, I try and have those conversations with the client and ask them, like, what was going on at this time, and see maybe did they go talk to their community mental health provider at that time and see if those records maybe offer a different perspective of what was going on. But at the very least, again, getting their story to see if you can, advocate for them within their MSR and let them know what was going on with them as far as their mental health goes and not just the substance use.
That's good advice, Rachel. So dig a little deeper, find other documentation. Like you said, use other collateral information, talk to the applicant about what was going on at the time. I think that's really great because that's often what happens. And you want to make sure that those are explained by finding out what was going on with that person at that time. Here's another MSR question, I think perfect for both Rachel and Amanda. I have been told by SSA that a well-written MSR is good, but without a doctor's signature on the MSR, it's not meaningful documentation. Is this true? And if so, what are our options? Amanda, do you want to take that one first?
Sure. So this is a common question that comes up as a recurring theme with SOAR technical assistance. So it's not considered medical evidence if it isn't co-signed by a qualified medical professional, but it is considered collateral evidence, which speaks to the functioning portion of the person's application. So you can still use your MSR as a really powerful tool to talk about the person's functional impairments, and particularly their functional impairments during periods of sobriety. if they have a co-occurring disorder. So it can be used to flesh out Part B of the listing requirements, but you do need a doctor's signature or a treatment provider's signature if you want the MSR to serve as criteria for Part A of the listings.
Very good, because that is often, a misconception about how valuable the MSR is, even those unsigned ones, because of the valuable functional information that it has. But you're right, to establish a diagnosis, that must be, signed, or to give it medical evidence weight. It must be signed. So, great. Melissa shared really great statistics on the number of adults who've experienced a traumatic event. About 90% of adults have experienced a traumatic event, and often many experience multiple traumatic events. So again, in understanding this and the high percentage that individuals who are experiencing homelessness, I think it was 75%, how important then is it to be able to help the applicant understand how their substance use history may impact their disability case? So this is really Amanda and Rachel. How do you have that conversation with the applicant about that, so that they are open and honest with you about sharing their usage, and, again, how you help them explain it to you, so that you can describe it in your MSR? Is that often a difficult conversation?
I can jump in here, and in my experience, I'm usually just very honest with them when I bring up the subject of substance use and tell them, I'm not here to get you in trouble, but helping me understand what's going on with substance use and your mental health is how we are going to make this application successful. So that way, when we're having those conversations, that generally allows them to open up a little bit more and understand that I'm not here, this is not a punitive thing. We're working together on this, and I'm really trying to figure out what's going on. And I make it very clear that the time frames are important for the sake of, getting that information from their medical records versus, getting their story, from their own perspective as well.
That's really good. Okay. This is a question for Amanda. You had mentioned that you use clinical records for finding more clues on ER, case management, and group therapy records. So the question was in regarding to the group therapy notes. This person said, I had a previous SOAR applicant who, when we requested his medical records, were told that they could only release notes on group therapy with a court order. Is there a way around this? So I don't know if it's a state-by-state type of question that we can look into, but Amanda, did you find them easy to get, and you were in Michigan?
So in Michigan and Colorado, I don't recall having a problem getting group therapy notes. If it was a private practice, sometimes I would have trouble getting individual therapy notes. So I think that might be a case-by-case kind of situation that we could work through together with strategies for talking to that records department.
That's good to know. So the person who asked the question, feel free to call email the TA center, and we can see if we can look into that a little bit for you. If those, would be very helpful, for your case, how the person was taken to group therapy, I guess, some of those comments. Okay. Here's a question that is kind of along the lines, and again, we see this a lot. What about a claimant who likely has DA&A but suffered a disabling injury due to his DA&A and is now disabled? So it sounds like while the person was maybe intoxicated, they were injured, and that injury may need a listing. how will Social Security look at DNA to deny them? Amanda, did you want to take that? That's similar to your case study too, maybe.
Yeah, so this is similar. If they have a condition, even if it was caused by drug or alcohol use, it doesn't disqualify them from being eligible for benefits. It doesn't matter how the person acquired their disability. If they have a disability that's going to prevent them from being able to engage in substantial gainful activity for at least 12 months, then they are eligible for SSI or SSDI benefits.
I think that's good. Yeah. Great answer for that. This question came in. It pertained to Melissa's information about veterans and the use of TRICARE. The question was, does TRICARE cover residential services? And I thought maybe if, Melissa, you have some information on this that you can share. We did get a response at the TA Center, but did you want to talk about that at all? Is that something you know about?
I actually would need to follow up with one of our other team members to get that answer.
Okay, yeah, so we were able to get from the TA Center that TRICARE has a number of health plans that provide a range of coverage. So to find out about eligibility for residential services, that we encourage you to contact TRICARE at their website, because then you could look into the individual plans. But again, yeah, if it's something the questioner wants more information on, just email the TA Center and we'll get that to our subject matter expert on that. And then there was also, Melissa made a comment about not all veterans can has access to the VA, which is correct. And we just wanted to share that because, again, Jen Elder at the TA Center answered that and said that is a common misconception that everyone who has served in the armed forces will have access to health care by the VA. So with eligibility enrollment for VA health services. So anyway, just wanted to kind of clear that up so the questioner has an understanding that Melissa's statement was correct. Melissa, did you want to talk any more about veterans and access to health care?
No, I think that you covered that. And again, I reiterate what you mentioned about reaching out and trying to learn what is available specifically on an individual basis, as what people can access really can vary based on where they're located and what those VA centers and hospitals have to offer. So yeah, it really is an individualized approach that you need to take.
Okay, that's great. Thank you for that. We have a few questions along those lines. We have a question here about trauma. And again, Amanda in her presentation shared the MSR interview guide that does have that substance use history section that has a lot of open-ended questions. But because Amanda and Rachel have a lot of experience interviewing applicants with co-occurring disorders, and we see in Melissa's statistics that a high percentage have traumatic events in their past, how do you, what are some strategies, Amanda mentioned compassionate interviewing, what are some of your strategies for eliciting this information from applicants, knowing that you're using this for their disability claim? Do you want to talk a little bit about that, some strategies for helping folks, again, understand why you're asking about their trauma history, especially if it's impacting their, current functioning?
Sure. So during my intake process, one of the key things I make sure to discuss with the applicant is we need you to be as open and honest as possible so DDS can understand the true story of your life. Not very many people have the opportunity to present something as unique as the medical summary report for their disability cases. So this is a really good opportunity to present this information in your own words, and it's my job to help tell your story. And that seems to be a pretty effective strategy. And just one example as it relates to trauma and substance use from a case I worked, I think it was one of my first SOAR cases back in 2010. This man presented really rough around the edges. He told me he's done every drug in the book but likes alcohol the most. So he was getting into a lot of fights on street corners. He just was really rough. He had a beard. He was scruffy. He just presented as a really tough guy. So we started talking about his alcohol use, and we went back. He said he was 7 or 8, and he was sneaking beers out of his parents' fridge. And I stopped and I said, 7 or 8? That's really young. He's like, yeah, I was just a bad kid. I was like, I know 7 and 8-year-olds, and I don't think they have that ability to be a bad kid. Was there anything going on that made you want to try that beer? And he got really quiet, and he said, well, my neighbor used to make me come over his house and help him put stuff away, but that's not really what he was doing. That's what he was telling my parents he was doing, and that's when I started drinking the beer. So that's all he shared with me, but that was enough context clues to get the idea of what was really going on with him. So I talked with his case manager about it with his permission, and they brought it up in their future appointments, and he ended up working through it in therapy throughout the SOAR process and ended up opening up a little bit more to me and let me share the story with his application. And it gave me a really new and strong insight into the root cause of his substance use history and how his use just progressed so much over time. And it brought out a lot of anger and emotion in him as well. And I just think that if we can create an environment where someone feels welcomed enough to share such personal details. He was 50 years old, and he said, I'm the first person he ever shared that with before. So it was just a really huge gift to me that he was willing to open up about that information. And I know it was traumatic, but I supported him and helped him connect with his case manager and therapist so that they could provide the further support that he needed to work through that trauma.
That's perfect, and that's a great illustration of how important it is for SOAR caseworkers to develop those trusting relationships. It's really how you're going to get information that you know is going to really help their disability case and really show the meaning behind their substance use. So that's a really great example. And also, looping in his therapist as well. Really great to show that you care and that you care about his mental health, especially knowing how difficult it was to share that information. It's really great. Now, we have another question that probably has come up quite a bit in the work that you've done, Rachel and Amanda. It's how would you suggest addressing comments in records saying that a client is med-seeking? That suggests perhaps it's not legitimate pain, whether it's physical pain or traumatic pain, right? Med-seeking. Have you seen that in medical records, and how do you kind of explain that? And what kind of clue does that give you when and if you have seen that in medical records, that they're just drug-seeking for pain medication? Something you've encountered, or any suggestions on addressing that?
I've encountered it before, but luckily in my experience, I've always had other records that kind of overshadowed that. So I'm not too sure how to go about it. If that's the only thing that they're marking on the visit is just the med seeking, I've often found that there's other things in those records that mark symptoms. And generally, med seeking would mean that they may not be using at that time. So if it does say med seeking, but they did maybe a toxicology report, and you're seeing that, you might find a clean toxicology report on there, even when the records say med seeking. It's just one of those situations that you might need to dig a little bit further and kind of look at the other evidence around. But like I said, in my experience, I've been pretty lucky to have other supporting documents on those. I haven't had one where that's the only one.
Right. Right. Well, that's helpful. Look for other documentation. Again, the individual could be in pretty serious, pain, and and there really could be a reason, for that related to their mental health diagnoses. That would be really good. We had a question here, and it's something we can talk about at the TA Center, but there was a request for copies of your MSRs for Rachel and Amanda. So that's something we can talk about and see if we can't take a look at them, get them redacted, and see if we can't upload those with the PowerPoint. So we'll look for those. Maybe that's something that we can do. So I think people are really interested in seeing how you do write your MSRs, specifically the substance use history sections as well, when you know that DA&A is something that could be involved in their case. So with that, we have a few more questions that we'll make sure that we get answered offline. We may have to get some more details on it. But we just want to, again, I just want to thank all of our presenters today for their wonderful and informative presentations and taking time to answer some questions that folks in the SOAR community had. So, again, I just want to, thank everyone for, joining us on this webinar. Don't forget to do the evaluation, and have a good afternoon. Thank you.